Well, it's getting better, mostly in the sense that there's a lot more people looking at this population. I think it's unique that we have less data about older adults with cancer, yet frankly, these are the majority of the patients we're treating. So I think there's a big evidence gap that I think we're slowly trying to fill and improve our understanding. It's a unique in this setting of, some patients do well, just as well as younger patients, and some patients don't do as well. And you're at risk of over-treating and under-treating. So it's kind of walking a tightrope as far as choosing the appropriate treatments for this population. I think we're getting better at developing tools so that people understand, who may benefit and who's at risk with treatment. We're still working on trying to make those, widely disseminated and widely used. We're using geriatric assessment here, particularly in some of our clinics in GI, to kind of personalize these treatments based on patient factors. There's good evidence suggesting that that's important. It's included in the guidelines, whether it's ASCO, NCCN, but I think we also recognize that it isn't being widely used yet, and that there's still a lot of barriers to getting that to be part of routine care, across the United States and across the globe. So it's getting better, and I will say part of it is the assessments of older adults, so we can personalize treatment. But there is another aspect, which is, how can we intervene and improve their outcomes, and I think just recently we've started to see some, studies presented at ASCO this year in particular, where we're starting to see specific intervention studies in this population that are suggesting that these personalized approaches really do help. Well, I think specifically when we're talking about the older adult population, I think we're finally getting more information about, who is at risk and who may benefit from these cancer treatments, really refining that discussion that we're having with patients about the risk benefit of treatment. Because right now it's kind of a little bit of a black box as far as understanding that. Understanding that a patient that has malnutrition may really not do well with chemo because of toxicities. And using that same example, the next step is trying to move to intervention. So we don't want to just say, sorry, you're at risk for severe toxicities. We want to say, look, you're at risk, but I think there are these things that we could do to try to mitigate or reduce that risk. Actually 2 studies, they haven't officially published, but were presented at ASCO that showed that they dropped the risk of severe toxicities by 10% by incorporating a geriatric assessment and doing interventions based on those measures. So I think with more evidence, we can kind of refine these treatment decisions. And then also on top of that, adding interventions to improve outcomes in these patients that are at risk is my hope. I mean, I think we can have these, and really on top of all that, understanding how this impacts function and cognition and all those other things that patients often ask.